Hi, this is Dr. Jason Lee, clinical immunologist and allergist practicing in Toronto, Ontario. Hello, and welcome to Lecture 6. In this final lecture, we're going to be talking about biologic-based treatments. Now, the oldest biologic known for treating asthma, and particularly allergic asthma, is allergen immunotherapy. Many people think of allergy shots as just a treatment for allergic rhinitis. In fact, it is a Class 1B, the second highest recommendation given out by Cochrane Review. There are 14 Cochrane reviews of the issue, and a number of other meta-analyses all favoring treatment. However, what people don't realize is that allergen immunotherapy has a 1A or an even higher recommendation for asthma. The numbers needed to treat for asthma is 3 to prevent worsening of asthma, and 4 for preventing an increase in asthma medication. The evidence is pretty clear-cut that it reduces bronchial hyperresponsiveness. The magnitude of the impact of this effect is similar to the range of inhaled corticosteroids, which I talked about in Lecture 4 as being very effective. Keep in mind this therapy has been around since 1900 when a guy named Curtis figured out that you can cure people of weed allergies by injecting them with weeds. Over time, over the next 100 years or so, people have figured out the exact mechanisms at the basic science level. This is a good review of all the stuff that we talked about in the previous lectures. When your body is exposed to an antigen that induces allergies, it's called an allergen. Once it's taken up through the epithelial barrier, it sees and encounters an antigen-presenting cell, let's say the dendritic cell. The dendritic cell will then process the antigen, presenting it to CD4 cell, a naive CD4 cell. If it encounters the cytokines 4, 5, and 10, it may distinguish into a Th2 phenotype, in which case the Th2 will produce IL-5, producing eosinophils. Eotaxin gets secreted, recruiting eosinophils. Other cytokines, such as 4, 9, and 13 interleukin families, will cause B cells to proliferate to plasma cells, producing IgE. The IgE then goes and coats the mast cells, basophils, and eosinophils. The mast cells and eosinophils that reside in the lungs will propagate asthma. Now, allergen immunotherapy we talked about is very effective, but how does it work at the basic science level? With allergen immunotherapy, it will suppress inflammatory dendritic cells by inducing IL-10 producing dendritic cells. IL-10 is thought to be a regulatory cytokine. The Treg cell will also suppress directly the Th2 effector cells. In addition, the T effector cell, which is Th0, Th1, Th17, Th9, Th22 effector cells are also suppressed. Th2 also, by being suppressed, will indirectly decrease the production of IL-4 and 13, which indirectly decreases IgE production. Because there is an increase in IL-10 and TGF-beta, the B cells will also be suppressed and induce a class switch from the IgM to IgG4 to cause blocking antibodies as opposed to IgE production. By blocking Th2, you will also decrease IL-3, 4, and 5, which decreased recruitment of mast cells, basophils, and eosinophils. Again, by decreasing Th2, you reduce the IL-4 and 13, which is also involved in endothelial cell proliferation. The T regulatory cell also directly suppresses Th2 cell honing to tissues. With a reduction again in Th2 activity, IL-9 and IL-13 is reduced, which causes less tissue remodeling. Now, Treg cells will also secrete TGF-beta, which also contributes to the decreased tissue remodeling. All of these things have been proven, and this is the mechanism of allergen immunotherapy. In Lecture 4, we learned that asthma can be controlled in most cases by using a combination of inhaled steroids and combination inhalers. In Lecture 5, we learned that you can design a targeted molecule based on a solid level of understanding of immunology behind the pathophysiologic process. We learned in 1 to 3 the very basic science that's required to design such biologics. Why do we need newer therapies, such as biologics? Well, approximately 5% of all asthma patients are severe, and this is defined as being unable to control the asthma despite maximal doses of conventional therapies. These 5% of asthma patients represent 50% of the healthcare spending in asthma. Biologics, as you know, there's a lot of interest because we can design safer and more effective therapies. It's the easiest way to form a customized targeted medication, and you reduce the number of collateral damage. So, we learned that mast cells are very important for this process in the lung, leading to inflammation. They release things like histamine, cystine leukotrienes, prostaglandins, cytokines. The mast cells can be triggered in a number of different ways, but one of the ways is by IgE antibody, which is an antibody originally designed to fight parasites and bridge the innate and adaptive immunity. This antibody is also on eosinophils, which also contributes to the inflammation. Eosinophils, like the mast cell counterpart, contribute by creating things like basic proteins, such as major basic protein, cysteine leukotrienes, and other cytokines to propagate the inflammation. So naturally, knowing this, you would think, well, what if we block IgE? It seems to be present on both the eosinophils and mast cells. The other strategy people thought of is blocking interleukin 5. As you'll recall, this is the major cytokine that activates eosinophils. How does making an antibody toward the antibody IgE work to reduce asthma? You remember the B cell will class switch into a plasma cell that releases IgE. If you bind to the free IgE, this eventually decreases cell-bound IgE at the mast cell, eosinophil, and basophil level. Over time, what this results in is decreased expression of high-affinity receptors, the Fc-epsilon-1. This thereby decreases mediator release and propensity of those cells to react, thereby reducing allergic inflammation. Clinically, this reduces severe exacerbation rates approximately by half, decreases emergency visits by about 43%, and decreases steroid use in approximately 78% of patients. IL-5 has been studied in multiple various forms. There's mepolizumab, benralizumab, and razilizumab. We all know that eosinophilia has been associated with bronchial mucosal hyperresponsiveness and bronchial hyperresponsiveness. If you biopsy these tissues, we find a lot of eosinophils. So in a subgroup of phenotype patients with asthma, they will improve with bronchial hyperresponsiveness, peak flows, and FEV1 with various forms of anti-IL-5 therapy. This in turn translates into reduced extracellular matrix protein remodeling and a reduction in measurable sputum eosinophils and airway eosinophils. Many other therapies have been tried to try to block asthma, and some of these, I would have to say, have mixed results. For the purposes of this lecture, though, I will focus on these two as they have the best evidence. Currently, omalizumab is on the Canadian asthma guidelines. My suspicion is that anti-IL-5 agents will also soon be on the guidelines for a select phenotype of asthma patients. This represents an exciting steroid-sparing and steroid alternative therapy for treating patients with severe asthma. And that is all.